busy day in Sacramento. Can people in the back hear me? Michael, can you hear me?
Yes.
Great. Most of you know me, and a lot of us have known each other for many years now. And I have to say we're very, very blessed to have some incredibly special guests today. In addition to yourselves, we have Bob Kaplan. Can you raise your hand? Bob Kaplan, when he was the head of Health Services Research at UCLA, before he left to become the #2 at the National Institutes of Health and the Chief Science Officer for the Agency for Healthcare Research and Quality, he very quietly, in his sweet Bob Kaplan way, wrote an NIH grant to support the Right Care Initiative to start working beyond our statewide goals with the health plans and the medical groups to apply it in one community. And he called me a couple months before he left for NIH and very, very quietly said, "You know, I'm so surprised to say I have some really good news for you, Hattie." And so he brought in a grant for us, and it was what enabled a lot of us to meet over time. So Bob just happens to be back in California now. He's working with Arnie Milstein at the Clinical Excellence Research Center at Stanford, and he's here with us to help us co-facilitate today. We have other very special guests with us, including Dr. DeMaria, who Dr. Arevalo will be introducing, as well as Dr. Bill Baumer. But if it weren't for Bob Kaplan bringing in the grant, we wouldn't have done the on-the-ground work to start our very first pilot, University Best Practices. And that pilot was something that we co-created from just a lot of conversations with brilliant people like yourselves. And we recruited Dr. DeMaria. It took me about 6 months to get an appointment with him because he was doing so much international travel at that time. And when I met with him, Dr. DeMaria being the founder of the Cardiovascular Center at UC San Diego, and I showed him the gold bar charts, like what you see on the back of your agendas. If you could flip over your agendas, you'll see the gold bar charts for Sacramento. When he saw the numbers for UC San Diego, he slammed his fist on the table and he said, "I am going to help you with this." I did not realize these numbers existed, and there will be some people hearing about it, and I promise you we'll be turning this around. And I will chair whatever you need me to chair to get this community effort off the ground. And now he's been our founding chairman of the University of Best Practices in San Diego for 6.5 years. And a year and a half after he started San Diego with me, Dr. Arevalo and I started Sacramento here, and now today is our 5-year anniversary, and I am so thrilled that we are making progress together. And the reason we're here is for people like Shannon Dornbrock, who we haven't met yet. She is an amazing family advocate, and I will let her tell her own story. Shannon, welcome. Please join me at the podium. And before she gets started, I'll just say thank you, Bill Baumer from UC Davis, for joining us as our new co-chair from cardiology at UC Davis. Dr. DeMaria and Dr. Baumer have known each other for many years, and now that they're both engaging, we'll see even greater success. So thank you, Shannon, so much for being with us. And with that, Katie, are you ready to go?
Yep, ready.
Yeah, thanks.
Hello, my name is Shannon Dornbrock. 10 years ago, I had a life-changing experience. My husband very suddenly died of a heart attack without any signs or warnings. He was 41 years old and at the prime of his life. At that time, we had a beautiful 15-month-old daughter who he cherished. And I was 6 months pregnant with our second child. But like a bullet to the heart, he was gone. I have asked myself several times of what we could have done to have changed the course of this tragic event, wishing that we could have seen the bigger picture of what was happening to him and prevent this ticking time bomb. I remember when I got the results of his autopsy. The person who performed it told me that the only way to have really detected what was happening in his heart was to have had a CT scan. Too many people, like my husband, are dying prematurely from heart disease. Heart disease is the #1 killer in the world and the #1 at breaking the hearts of families and friends who have lost their loved ones. I believe CT scans will save millions of lives. Knowledge is power, but knowledge is of no value unless you put it into practice. We must spread the knowledge of what CT scans can do and implement them into current medical practice. As women at the age of 40, it is recommended to have mammograms. It is imperative that men at the age of 40 have CT scans. Please join me in this proactive endeavor. I say this from my heart, for the heart. Thank you.
So again, welcoming you again on behalf of the Right Care University of Best Practices. For those of you who don't know me, my name is Jose Alberto Arevalo. I'm the Chief Medical Officer for Sutter Independent Physicians, and I've been very fortunate to actually run into Hattie Hanley and develop a close working relationship with her as we identified the opportunities here in Sacramento and learning from the great work that Dr. DeMaria and all people in San Diego have put together to create a collaborative like this. And we try as much as possible to create something here that could do the same thing. But the great work in San Diego, I have the privilege of introducing Dr. DeMaria. Before that, I wanted to again thank you for being here because this is really about you and a collaborative about you, the work that you do, and your passion to reduce cardiovascular complications in the Sacramento region. And continuing to come here after 5 years, and this is a milestone for us because 5 years ago when we started this, we had hoped that we would still be meeting around this time, but always there's a diminution of energy and passion sometimes over the course of time. But last time, as you know, we had over 70 people come to our Right Care meeting. So I know that July tends to be a time of vacations, and especially link it close to the July 4th holiday. But you're the people who are here today, and we want to thank you for being here and for being here on our 5th anniversary. And I wanted to, again, thank Hattie, because if it wasn't for Hattie and her vision and the work and her passion, you know, I don't think we have accomplished as much as we've done in the 5 years. And I believe that she deserves a round of applause herself. Actually, I've learned a lot from Hattie about patience, about dedication, about commitment, and I really am very privileged to continue to work with her. And our new co-directors, Dr. Palmer, as well as you know, our Dr. Thompson, who couldn't be here today, who's our other co-director, and wanted to thank her. And also, I wanted to recognize, you know, that Don, because Don is also someone that I feel has done a lot for cardiovascular risk reduction in Sacramento in his work, both personally as a family physician as well as a Chief Medical Officer for Western Health Advantage, and as well as one of our previous co-directors. So I wanted to kind of do a shout out for Don, and thank you, Don, for being here. So I have the privilege of course, introducing Dr. DeMaria, Anthony DeMaria, who probably doesn't need any introductions to people here, because he really, along with Hattie, has been instrumental in starting the Right Care and now the Be There program in San Diego. And through the generosity of the White Family Foundation, the University of Best Practices Right Care Initiative is now called the Be There campaign. And the work that has happened in San Diego around collaboration of competitors is something to be envious of, and that we have tried to emulate here. And again, this is really, really passionate work for someone like Dr. DeMaria, who's an international expert and who has trained cardiologists throughout the years, previous editor-in-chief of the American Journal of Cardiology, as well as a leader internationally, publishing thousands of articles. And we are very fortunate to have Dr. DeMaria here today. And again, he's going to talk to us about towards the elimination of heart attacks and strokes, which is what we're here, and wanted to help join me in thanking him for being here today.
Okay, well, it's good to be back. Actually, I was a cardiology fellow at UC Davis more years ago than I'm going to admit at the moment. And early in my career, worked with Dr. Balmer. He's aged a bit better than I have, but we've both been around for a long time. And actually, as I recall, I was the inaugural speaker at this University of Best Practices 5 years ago, so I'm on track, I guess, to speak every 5 years or something like that. But as you've just heard, Hattie is like this colossal magnet. And if you come anywhere within her operative field, you get drawn in, you get immediately sucked in and attached, and that happened to me one day quite innocently when I was sitting in my office, and Hattie came in, and the next thing I knew, I was in the middle of what was then the Right Care Initiative that we now calling San Diego Be There. So we got started a little bit early, and I thought as a 5th year anniversary, it might be of some interest to just review our program there. Let me remind you, as you just heard from the very moving speech in the beginning, that cardiovascular disease is the #1 killer in the world. And in fact, it used to be that an American died of heart disease every 30 seconds. so that in the time I've been speaking, about 6 Americans would have died. It's a little bit less now, and it results in an annual cost of $350 billion. So an enormous problem. And what's also of interest is to recognize that we tend to focus on the highest risk patients. We always tend to focus on those patients who have symptoms or have some other evidence of heart disease, and that's reasonable because the mortality rate is extremely high in that group of 15%. However, that group is very, very small. And in fact, if you look, the patients who are at intermediate or even at low risk have a much lower incidence, but there's a huge population, so that paradoxically, if you look at absolute numbers, there's more patients who will experience cardiovascular events from the intermediate and low groups than there are from the highest risk group. And so that got our focus early on the fact that if we were going to make a difference, if we were going to impact cardiovascular events, we should be looking certainly at the whole spectrum, but particularly at these lower risk groups, because they were being under-identified. So that we all know that there are risk factors for coronary disease. Now, about 20% of all people who have cardiac events have none of these identified risk factors, but about 80% will have one or more of these risk factors. And the ones that are easily modifiable are the ones we're all familiar with: cholesterol, particularly low density cholesterol, elevated blood pressure, elevated triglycerides, tobacco, smoking, inactivity, obesity. We're all familiar with those. And we used to have the non-modifiable risk factors, although in this day and age, gender has been recognized as being more modifiable. But other than that, you can't alter your family history, your age, or your personal. But together, these risk factors are prominent in about 75% of people who have cardiovascular events. And therefore, it's been estimated that if you reduce those risk factors, that perhaps 70 to 75% of cardiovascular events can be eliminated just by reducing the risk factors. Now, could this be true? Are there data to support this? And the first data was really one of those seminal manuscripts that receives all kinds of attention. Two British physicians, preventive medicine physicians, Walden Law, and they went through the medical literature and they carefully identified the amount of risk reduction of cardiovascular events that would result from lowering the LDL or bad cholesterol, treating blood pressure, homocysteine, at the time not so important, but also altering platelet function with something like aspirin. And what they found was, if you added up the benefit of all these interventions, that in fact, by their calculations, you could reduce coronary events by 84 to 90%, and you could reduce the incidence of stroke by 70 to 87%. That was their calculation. Well, they followed a number of other manuscripts, this one being very prominent. Again, a careful analysis of the individual reduction in events, so that the cumulative reduction, if you use all of these interventions, aspirin, beta blockers, lipid-lowering treatment, and ACE inhibitors for blood pressure, that you could potentially, theoretically, reduce the number of cardiovascular events by 75%. So it was just a matter of time till somebody took all of these articles, put them together in a meta-analysis, taking the whole spectrum of data, and what they demonstrated was the potential of reducing coronary events by 70 to 80% and strokes by 65 to 75% just by reducing risk factors. Now, one of my favorite sayings in the whole entire world, and I take no credit for this, it's come from a number of other sources, but one of my favorite sayings is that everybody has to die of something. You just don't want to die of something stupid. And if you don't lower your risk factors and die of a heart attack or stroke, that's just dumb. That's plain dumb. So that we had our marching orders to reduce risks. Well, why weren't risks being reduced? Well, one problem that we have to take, as Bill and I were talking about earlier, that we have to stand up and take as physicians, is that there is a general underutilization of cardiac interventions of proven benefit. If you take in the coronary realm over here, beta blockers, you can see that less than 40% of patients who have a proven indication based on scientific literature are actually getting those medications. Of course, this goes back to about 2002. So that clearly there was room for improvement in terms of physician behavior, and that is what we see here and now today in your university of best practices. But patients also were a major factor, first of all, in just presenting themselves to identify risk, but then, once risk was identified and adhering to their medication, catchy phrase, drugs don't work in patients who don't take them. And adherence is very poor in general, but it's particularly poor in preventive medications for which no symptom is being experienced. And in fact, as you can see from this manuscript in JAMA, looking at adherence to statin therapy, 50% of patients initially given statin therapy were no longer taking it in just 4 months. 25% of patients with heart attacks who get statins prescribed in the hospital don't fill their prescription when they leave the hospital. So doctors could do better, patients certainly could do a lot better, and that led to what we call Be There San Diego. And our mission was to eliminate heart attacks and strokes in San Diego, and to make San Diego the first heart attack-free zone in the United States, in the world. Why settle for the United States?
And I have to say that when he said, let's do the first heart attack free zone, I said, I'm in if you add stroke.
Yeah.
Heart attack and stroke free zone.
I did say that, didn't I, stroke? Maybe I
You
didn't.
left it out.
I left it out. Okay. And so when we first thought about this, you know, this is frequently termed the BHAG, a big, hairy, audacious goal. I mean, think about that you could do that in Sacramento. Say, Sacramento is going to race San Diego. And if you are a citizen of Sacramento, you're not allowed to have a heart attack in the next year. Now, that accomplished one thing, really, by doing this. San Diego, we're very spoiled and we're very arrogant. We think we've got the best life in the whole entire world, the best weather, the Pacific Ocean, etc. And so, what we did was to say, let's be the best at reducing heart attacks and strokes. and make it a community effort, not a doctor effort. When you make things a doctor effort, it's a whole lot harder. If the community says that this is something they want to do, then it's likely to get done. So we wanted to activate patients, and we wanted to get all the providers together to find out who was doing the best in reducing risk factors, so all the rest of us could copy what they were doing, what the University of Best Practices. So how do you activate patients? Well, we thought the best way to do it would be going emotional, because people tend to be willing to change their lifestyle more if there's an emotional tug, and especially people are willing to change lifestyle if it's going to benefit a loved one more than themselves. You say to somebody, you need to stop smoking or you're going to die, and you say, you have to stop smoking because you'll die and you won't be there to give your daughter away at her wedding. Then oftentimes that makes more. So we created some literature, Hattie and Liz will remember this, to make this point, to be there, take care of yourself, to be there for somebody else. So here's a grandfather teaching their grandson to surf. His first perfect wave, be there. Here's an African-American father dancing with his daughter at her wedding. It's her time to shine, be there. And then we got a little bit rougher, a little bit harder edged, and we began to ghost out the potential patient. And then the thing I miss most at is our heart-to-hearts, or my own personal favorite with a young man, his father ghosted out, reading, "Dad, you never let me win. Now I would do anything to have you beat me one more time. You know, Dad, take care of yourself." So we got everybody together in San Diego, and that's really the secret. That is the secret sauce. And that's really what Hattie managed to pull off, because we got the physicians from SHAR, from Scripps, from UCSD, we got all the community clinics, Arch Health Partners, we got the multicultural group from the South Bay, Kaiser Permanente, important relationship with the San Diego Health and Human Services, and put all of these pieces together and came together as a community. It wasn't easy. I don't know, Bob, if you were there, but you know, San Diego's an incredibly competitive marketplace from a medical perspective. You bring all of these competing factions into one room. We had to insist that everybody leave their guns at the door, and everybody came together and said, for this project, we're going to share our data. We're going to tell you what percentage of our patients with hypertension are controlled and not controlled, what percentage of our patients with LDLs are elevated, and whoever's doing the best is going to tell us how they did it. It's really, to this day, I'm not sure I know of another community in the United States that does that. We give our data to RAND, and RAND processes it and then gives it back to us. So I'm going to move quickly. In the process of doing this, there was a solicitation for grant proposals from the Innovation Center, the Healthcare Innovation Center, to propose new payment and service delivery models that will provide better health, et cetera, et cetera. So we applied, and lo and behold, we got it. And so what we proposed was that we were going to implement a program. And the program was going to involve every center in San Diego, that we were going to do two things: bundles of medications and healthcare coaches to contact these patients continuously And we propose that by